Dear Professor Salong Ki, Chairman, ladies and gentlemen, it's a great pleasure for me to give a speech in APASL Single Topic Congress 2020 Guangzhou. Also, I would like to congratulate Professor Ki and his team to organize this very important meeting in this challenging period of pandemic. Today, I am going to speak about ultrasonic assessment for the diagnosis of portal hypertension. Portal hypertension is a common clinical syndrome characterized by an increase in portal venous pressure. There are invasive and non-invasive methods for the diagnosis of portal hypertension. Gold standard methods for assessing portal hypertension include the measurement of hepatic venous pressure gradient, endoscopy, CT, and MR angiography. But there are invasive, expensive, and not available at all centers. Therefore, non-invasive alternatives have been the subject of extensive investigation. The measurement of hepatic venous pressure gradient is considered as a safe and reliable procedure indirectly to individuate the portal pressure and monitor the portal hypertension. Hepatic venous pressure gradient value above 5 millimeter mercury is suggestive of portal hypertension. Hepatic venous pressure gradient is a surrogate for the portosystemic pressure gradient. Clinically significant portal hypertension is defined as a gradient greater than 10 millimeter mercury, and variceal bleeding may occur at a gradient greater than 12 millimeter mercury. Ultrasound is the first-line imaging examination to be performed for the diagnosis of portal hypertension. Ultrasound is safe, repeatable, inexpensive, and highly sensitive in detecting thrombosis in the portal vein and hepatic vein. But intestinal gas and obesity limit the examination. Ultrasound easily shows changes in liver morphology and signs of portal hypertension. It's necessary to have an advanced training and comprehensive knowledge for optimal usage of ultrasound for the diagnosis of portal hypertension also. There are two signs which are 100% pathognomonic for the diagnosis of portal hypertension. The first one, portosystemic collaterals, such as paraumbilical vein, splenorenal collaterals, coronary vein, and others. And the second sign is reversal of flow in the portal vein system. Splenomegaly is commonly associated with portal hypertension, but is not specific. Also, portal vein dilatation higher than 13 millimeter in diameter, ascites, and occluded hepatic veins are less pathognomonic signs of portal hypertension shown by ultrasound. Beam mode ultrasound provides fundamental tissue images measuring vessel diameter and spleen size to identify the ascites and demonstrating abnormal collateral root. I always remember my mentor, Professor Kunio Kuda's words. Ultrasound is like a stethoscope for the gastroenterologist and will be so in the future also, emphasizing the promising future of ultrasound. And now, ultrasound became a must diagnostic method for all patients' examination. One of the earliest studies for the ultrasound diagnosis of portal hypertension, titled Collateral Veins in Portal Hypertension, Demonstration by Sonography, published at American Journal of röntgenology in 1981. In this study, diagnostic value of real-time sonography for portal hypertension was evaluated in 38 patients with collateral veins using a linear array scanner in comparison with percutaneous transhepatic portography. We demonstrated that the frequency of detection of collateral by sonography relative to that by percutaneous transhepatic portography was 85% for the coronary, 100% for the prime umbilical vein, and 10% for the short gastric veins. We conclude that ultrasound is perhaps the first choice procedure for the demonstration of collateral veins and diagnosis of portal hypertension. Recent developments in digital technology have introduced various imaging modes: color-powered Doppler, harmonic imaging for contrast enhancement, three-dimensional visualization, and fusion imaging. Doppler ultrasound, with the advantage of real-time observation of blood flow, evaluates the severity of liver disease and portal hypertension. Doppler ultrasound evaluates the patency of portal vein system and reverse portal flow. And also, Doppler ultrasound can be used to follow up the patency of translocular intrahepatic portal systemic shunt and proved useful to save unnecessarily invasive hemodynamic procedures. Portal hemodynamic are predictive markers of outcomes in cirrhosis. Lower velocity, less than 12.8 centimeters in the portal vein trunk in compensated cirrhosis for decompensation, and reverse portal flow in demonstrated cirrhosis for poor prognosis. Also, it provides presentation of the velocity by color scale, but the effects of the Doppler ultrasound to predict the severity of portal hypertension may still be debated due to the lack of definitive parameters. Robinson and his colleagues pointed out that coronary vein can be demonstrated the most prevalent and clinically important by Doppler ultrasound. Also, they detected flow directed away from left portal vein through umbilical vein, indicating of the recanalization. Endosonography is not non-invasive procedure, but may help the diagnosis of portal hypertension, demonstrating esophageal varices, dilatation of short gastric veins, and other collaterals. Also, two major diagnostic applications of endoscopic ultrasound guided interventions include angiography and assessment of intravascular pressure. Contrast enhanced ultrasound is applied to differentiate diffuse liver disease and assess the severity of portal hypertension. Recent studies show the diagnostic abilities of contrast parameters based on dynamic microbubbles for portal hypertension. Contrast-enhanced ultrasound provides analysis of transit time of microbubble contrast agent through the liver. It was demonstrated that decrease in the transit time between the hepatic vein and the hepatic artery or portal vein is related to the degree of portal hypertension. Subharmonic imaging is a novel technique using a characteristic property of microbubble. There is a good overall agreement between the subharmonic aided pressure estimation gradient and hepatic vein pressure gradient. Eisenberry and his colleagues reported that the diagnostic abilities of the subharmonic aided pressure estimation gradient were 89% sensitivity and 88% specificity for the patients with clinically significant portal hypertension. Since the primary cause of portal hypertension is the mechanical increase in intrahepatic resistance due to fibrosis and distortion of liver architecture, it's reasonable to assume that non-invasive parameters of liver fibrosis may indicate the presence of portal hypertension. So, as the principle of elastography, it is non-invasive medical imaging technique that helps to determine the stiffness of organs most commonly used for liver. Transient elastography is a novel, non-invasive, safe, and easy to perform technique that gives information on the level of fibrosis by measuring liver stiffness through the transmission of mechanical waves into the liver tissue and after analysis of the wave propagation and liver tissue deformation. Liver fibrosis is the first and main determinant both of tissue stiffness and of the intrahepatic resistance to portal blood flow. Obesity, presence of ascites, and increase of the ALT value are all limiting factors that may impede a precise measurement of liver stiffness. Liver stiffness reveals the grade of portal hypertension and thus predicts the presence of varices. A strong correlation comparing liver stiffness and in diagnosing portal hypertension was found when hepatic venous pressure gradient was below 10 mm mercury. But there is a meta-analysis from 18 studies showed the utility of transient elastography for detecting significant portal hypertension. There are some studies demonstrated that transient elastography is a very good predictor method for the assessment of portal hypertension. Acoustic radiation force impulse elastography with any B-mode liver ultrasound scan gives a detailed and reliable information on the severity of liver fibrosis. The mean shear wave velocity measurements in the liver and the spleen demonstrated a good correlation with the portal vein pressure measured with hepatic venous pressure gradient. However, spleen elastography is inferior to liver elastography for the detection of portal hypertension. It was asserted that shear wave elastography is better than transient elastography, showing the liver and spleen stiffness. Moreover, shear wave elastography more successful than transient elastography technically. There is no data using two-dimensional shear wave elastography and strain elastography for diagnosis of portal hypertension. By using MR elastography, a higher spleen stiffness and strong correlations between hepatic and splenic stiffness were demonstrated in patients with cirrhosis. According to current data, we can say that MR elastography in detecting portal hypertension is a promising method but needs further studies. In this busy slide, it was shown that almost all diagnostic methods using or including somehow ultrasound waves have significantly higher accuracy rates with high sensitivity and specificity values for the assessment of portal hypertension. As a conclusion, ultrasound imaging very useful, non-expensive, safe, repeatable, and first-line imaging examination to assess for the diagnosis of portal hypertension. The Doppler technique offers real-time observation of blood flow with qualitative and quantitative assessments, and the application of microbubble-based contrast agents has improved the detectability of peripheral blood flow. Different techniques of elastography for the liver and spleen covers a wider field beyond the original purpose of fibrosis assessment. Developments of ultrasonic technology enhance the practical use of ultrasound in the assessment for the diagnosis of portal hypertension. Thank you very much for your attention.